So one of the ways you can think about this is it's like having termites on the inside of your brain cells, your neurons, and some of the other helper cells in the brain. They've been found in those cells as well as many others throughout the body. So that's the bacterium, and that's how it gets throughout the body and has been associated with Alzheimer's in the brain.
Welcome to Let's Talk Alzheimer's, your place to go for the most up-to-date conversations with world-renowned research scientists and doctors. And now, Let's Talk Alzheimer's with your host, Nancy Keach.
Welcome to Let's Talk Alzheimer's, a podcast from BrightFocus Foundation's Alzheimer's Disease Research Program. Today, we are sinking our teeth into the connection between Alzheimer's disease and a common strain of bacteria called P. gingivalis that is found in the gums and in the brains of many Alzheimer's patients. A once-daily oral pill targeting P. gingivalis is actually showing promise in slowing cognitive decline in infected patients. That pill is being evaluated in a clinical trial called the SPRING trial, sponsored by Lighthouse Pharmaceuticals. I spoke with Dr. Michael Detke of Lighthouse Pharmaceuticals to learn more about this investigational drug and about the trial. Here's our conversation. Welcome, Dr. Detke. We're so grateful to have you today.
Thank you, Nancy. It's a pleasure and an honor. So thank you for having me.
It's great. But so many people responded. What an interesting subject we have today. So we received about 100 questions in advance, and they focused broadly on 4 categories that we're going to try to cover. What is P. gingivalis, this oral bacteria that we're looking at here? What mechanisms cause the connection between this bacteria, P. gingivalis, and Alzheimer's? What is the SPRING trial, and how can people participate? And then there were a lot of questions about dental and gum health overall, and we'll see, Dr. Detke, I know you're not a dentist, but we'll see which of those you feel comfortable with. So I want to start with 2 quick questions. Donna from San Jose, has clinical research shown evidence of certain gum bacteria or disease as a possible cause of brain disease related to Alzheimer's? And Katie from Brunswick, Georgia, how does bacteria in your mouth affect your body and the potential for Alzheimer's disease? So first, let's start. Can you just explain for us what is P. gingivalis?
Porphyromonas gingivalis is the full name, and I'll usually refer to it as P. gingivalis or just PG. It's a bacteria, you've heard of streptococcus bacteria, pneumococcus, and other bacteria like that. It's a bacterium that gets into your body. It is best known for being found in the mouth and for being associated with gum disease, not the teeth, but the gums. And the mild form of that is called gingivitis. And when it gets more severe, it's called periodontal disease or periodontitis. In the scientific literature on periodontal disease, many bacteria in the mouth are considered to be involved with it, but they commonly refer to P. gingivalis as the keystone bacterium, one of the key ones in the that is causing gum disease in the mouth. And that's been known for a lot of years. In the last couple of decades have come many papers that show that while you swallow your saliva, PG goes through your entire gastrointestinal tract. And it has been associated with diseases in the mouth, such as oral and esophageal cancer, but it also goes throughout the entire body. One other way that it spreads through the body is that it goes inside of other cells. Most bacteria are on our skin, in our bloodstream, in our mouth, but they don't go inside of cells. And it can go inside of your white blood cells, and then those go throughout the entire body because of the circulatory system. So we found its effects involved in several things, such as plaques in your arteries that can be associated with heart attacks, but they can also be associated with ischemic dementia, if you will, another form of dementia. So that's the bacteria. As I said, it's very unusual actually in 2 ways. One is that it gets inside of cells, and the other is that most bacteria live off of some sort of carbohydrate, a sugar, right? And these live off of proteins. These bacteria, that is their food source. So it has evolved to release these molecules that are like little scissors They're called proteases, which specialize in chopping up other molecules inside of the cell. So one of the ways you can think about this is it's like having termites on the inside of your brain cells, your neurons, and some of the other helper cells in the brain. They've been found in those cells as well as many others throughout the body. So that's the bacterium, and that's how it gets throughout the body and has been associated with Alzheimer's in the brain. This is a complicated slide, but let me just point you to a couple things. At the very bottom, it says intracellular. That's inside the cells. And at the top of the figure, it says extracellular. That's outside the cells. And look at the pink pill-shaped objects for a minute. That's how we depicted the bacteria, P. gingivalis. And then it releases these. They're called proteases. They are also called gingipanes from the gingivitis literature. And we depicted them here as these little orange Pac-Men because they're like Pac-Man. They go around chewing up things. And so on the left is the infection. And then on the right is we've made a number of drugs that we referred that are depicted here like little diamonds or gemstones. And they bind to the Pac-Man, they bind to the proteases and bind permanently and deactivate them. So then they're just cleared out of your cells. And by doing that, it stops chewing up the things on the inside of the cells. Well, first of all, it can kill the cell. So we know in Alzheimer's disease, you lose neurons, and actually there's some brain shrinkage. This may be part of why that's happening. And then when we stop it, again, depicted on the right with the gemstones, that stops all the pathophysiology, the disordered stuff, the damaged and destroyed cells. So that's how the drug works, and that's how we think P. gingivalis works.
Sarah, great question. Is PG found in the brains of healthy people as well as those that may have AD?
That's a great question, and that's one of the many pieces of science that supports this hypothesis. So one study that we did with a brain bank in New Zealand, actually, Neurovalida is the name of the group, and we've published this. People upon death can donate their brains to have research done on them, and this group had a large number of brains of patients who had Alzheimer's disease, but also people who died at the same age. And it's important to age match because some natural aging does things to the brain. And they were age matched patients who died of something else. They died of a heart attack or a stroke or a car accident. And we found that the evidence for PG and these gingipanes, these scissors inside the cells it was about 90 to 95% of the patients with Alzheimer's disease. But interestingly and importantly, it was about a third of the other patients too. Now, this difference was highly, highly statistically significant for those of you who follow that sort of stuff, meaning it's a really meaningful difference that it was 95 versus 33% approximately. But consistent with our hypothesis that this infection happens and then it takes a while to start damaging cells and building up clinical outcomes like memory loss, you would have expected not to see 0 patients that died in a car accident. Because you'd expect that some of those patients had this infection. Maybe they'd had it only for a year and it takes 10 years to work. So that was exactly what we would have expected as an outcome for that. And going back to the earlier question, again, there's all the earlier question about how is this related to Alzheimer's disease. Another study was by a colleague in the United Kingdom. And what they did simply was follow patients with gum disease, with periodontitis, who also had Alzheimer's. And they followed another group that didn't have periodontitis, but had Alzheimer's. The one with periodontitis declined by about 6 ADAS-Cog points. That's a standard scale that's used to measure cognition. So their cognition got 6 points worse during the year. And the group that had no periodontitis, they got 1 point worse. That's a bigger difference than most of all the drugs on the market. So just having periodontitis versus not in this study showed that you were much more likely to have your Alzheimer's progress and worsen during a 6-month interval. Evidence like that, just the evidence that many people with tooth loss or periodontal disease are at higher risk for Alzheimer's. You may all know that a couple of the leading risk factors for having Alzheimer's One of them is level of education. So a higher level of education, presumably spent more time reading and mental exercising, is a defense against Alzheimer's, and lower level of education is a risk factor. The second biggest risk factor, and this is in about 15 academic papers that have been published, is periodontal disease. So if you have gum disease in your mouth, you are at higher risk for, developing Alzheimer's and progressing more rapidly with Alzheimer's.
There were a lot of questions submitted relating to that and how to try to avoid having your mouth affecting your brain that way, which we're going to get to. So Deborah from Santa Barbara, California asked, how does the bacteria in your mouth get past the blood-brain barrier?
Yeah, that's a great question, and good use of the right medical term, blood-brain barrier. A lot of things can't get into the blood because the brain because of that. It's a challenge for us drug developers to design drugs that do get into the brain. Our drug does get into the brain, as Prozac and all the brain drugs do have to get in the brain to work there. So it's not an insurmountable challenge. But there's a couple of ways that we hypothesize that they get in the brain. We know they get in the brain because we've demonstrated this many different ways. The one is a simple route, which is in the just above the surface of the roof of your mouth, and just below your frontal cortex in the brain is there's a bone there. It's part of your skull, and there are holes in there that have nerves from your nose called the cribriform plate. And when people have studied this, once the PG's in the mouth, within a day or two, it can go into the brain. And in fact, in that frontal area of the brain is also the olfactory lobe, and it's been seen in there. And that, we think, is one of the reasons why people have a loss of smell when they have Alzheimer's. That's a very common, it's not 100% of people, but it's much more common to have anosmia, which is the loss of a sense of smell, in Alzheimer's than in the general population. So that's more evidence. There's another way they can get in the brain too, though. It's a really sneaky little bacteria. It has developed a number of things that we call immune evasion strategies to get away from your body's immune system. And one of these is that it can go inside of other cells, as I mentioned. And again, that's very unusual. But we've demonstrated that it goes inside of some of your white blood cells. And then those go out around your entire body, because everywhere that your bloodstream goes, it can take these. So we know it goes into the brain, and it's been associated with Alzheimer's and some other brain diseases like Parkinson's. We know it goes through the GI tract, and it's been associated with oral and esophageal cancers, liver disease, and ulcerative colitis and things like that. But it also gets into the bloodstream, and it's associated with atherosclerosis and other diseases. Atherosclerosis can be, as you know, a risk factor for ischemic dementia. And many dementias clinically present as mixed dementias. The dementia is memory loss. The most common form of it is Alzheimer's, about 60, 70%. The next most common is what I called ischemia. It used to be called multi-infarct. And way to think of it is it's like having a heart attack, but in your brain. There's usually a clot. Sometimes it can be a bleed, but there's a problem with a blood vessel. And then the blood vessel is supplying those brain cells with oxygen. So if there's a problem with the blood vessels, some of those brain cells die off. So, and an infarct is tissue dying. So if it's in your heart, it's a myocardial infarct. And if it's your brain, it's a brain infarct. Sometimes there can be, that will not present like a stroke, especially if there are many tiny small ones. So that was the old term, multi-infarct dementia. So it's basically kind of small strokes in the brain that impair memory.
And is that commonly referred to also as vascular dementia?
Vascular dementia, ischemic dementia. Yes, exactly. Same thing.
Okay. Richard from Belleville, Illinois asks, what sort of gum symptoms would indicate such gingivalis? I am in early stage of Alzheimer's. And John from Brick, New Jersey, how do we look for early symptoms? So how do you recognize that you have something wrong?
The clinical symptoms are that your gums can become more tender and swollen and bleed easily. Oftentimes people notice they're bleeding when they floss and or brush. The best things you can do to prevent it are good oral hygiene, brush twice a day, floss every day. You can use an antimicrobial, antibacterial mouthwash. And of course, see your dentist regularly. In addition to those symptoms, what your dentist should do, probably starting at the age of 50 or so, is if you've ever been to the dentist and they have that little thing where they poke down between your tooth and your gum, and they go around and poke down like 3 times on each side of each tooth, the kind of left side and the right side of the middle. They're actually measuring the pocket depth, which is here's a tooth and here's your gum next to it. And there's a little pocket in between. And at 3 or 4 millimeters deep, that's okay. Once it gets more than 5 or 6 millimeters deep, that's a sign of periodontal disease or gingivitis. And then you might be referred to a periodontist or someone who specializes in gum disease, and they can do more significant treatments, but they basically scrape some gum tissue off. It's called root scaling and planing. That's the only real treatment now. They also can use some local antibiotics, which can help a little bit, but do not really get rid of the P. gingivalis. So those are some of the things you can look for. Those are some of the things that you should talk to your dentist about.
So Kirsten, who I think was who wrote in on the chat here, Kirsten from Delmar, New York, sent in a question. How does one find out if they have this particular bacteria? Is it a given when one has gingivitis or periodontal disease? And I know you just answered part of this, but if the dentist, pokes in there and realizes that something is wrong, or if you're sensitive and bleeding, does that definitely mean it's a PG, or could it be something else?
It could be other things. It's not, PG isn't the one and only cause of gingivitis and periodontitis. There is a test for PG that your dentist can order or a doctor can order. Unfortunately, there's no treatment for it right now other than our experimental treatment, which we'll get to. And I left out something really important about P. gingivalis, the bacteria too, which is that you can't treat it with the current antibiotics that are on the market. And it's a really important point, because obviously if we could cure some cases of Alzheimer's with, a week of penicillin. People have shown that repeatedly. It is especially the periodontists who've known it's a part of gingivitis for a long time. They've been trying to kill it with antibiotics, and they don't. Again, I referred to immune evasion. This bacteria has evolved over many years, and it can hide in what are called biofilms in the mouth where antibiotics can't get to them. They can also become dormant, and they can become antibiotic resistant. And finally, again, they go inside of cells. So it's one cell inside of another cell, and a lot of drugs don't penetrate inside of cells. So there's no treatment for P. gingivalis today, with the possible exception of our experimental one. But there is a test by oral DNA labs that your doctor can order. We're using oral DNA labs to run our test in our study.
Is testing / saliva early detection conducted in a neuro visit? And we had another question from Darlene in Bolingbrook, Illinois. Which professional would initiate the testing? Is it your dentist, your neurologist, your internist? So how does that usually happen? Or can you ask for it?
Historically, because there's not a treatment for PG, it's not a test that a lot of people have ordered. It is best known in the periodontal literature. So a dentist or a periodontist would be most likely to order it. It's still in the investigational era for Alzheimer's. So I don't think most neurologists would even know what this is. It's just not quite ready for that prime time yet.
Yeah, and somebody asked, I don't have the question here, but somebody asked, are you sharing this with the dental associations? Are you sharing this? And I think that's going to come in time as we know more about how this can be treated and what mechanisms are that's actually happening.
We are reaching out to the dental community. In a prior trial, we did a periodontal sub-trial with a subset of patients who also could access a periodontal clinical research site, and as well as the Alzheimer's site. One of our scientific advisory board members is Mark Ryder, who is not an Alzheimer's expert, but he is the former chair of periodontology at UCSF. And so he's taught us a lot about that. I certainly am speaking to my regular dentist, whom I see every 6 months, about this, and she's fascinated by it. And I'll say one other thing too that she would be mad at me for forgetting, which is that dental hygiene is good for, it's been connected to so many other diseases, that good flossing and brushing and mouthwashing and regular dental visits are very important to your health, period.
Fantastic. And we're going to get into that a little bit more. But the last question before we start to talk about the trial that is active now is Blaney from Louisville, Kentucky. Any correlation with Lewy body dementia? And Charles from Massachusetts. Does gingivalis also impact or cause primary tauopathy? I know a lot of people won't know exactly what that is, but can it cause these other types of dementias?
We don't know yet. The short answer is we don't know that it would be relevant in frontotemporal dementia or any of the others. Those would be things we'd try. As we covered earlier, Alzheimer's is the most common. The most evidence for this being involved is in Alzheimer's, so that's where we want to test it the first so we can help the most people. To get into mechanisms for just a half a minute, they're both the amyloid plaques, but the amyloid molecule has been shown in a series of papers by Dr. Moyer from Harvard. They are what are called antimicrobial peptides. So they're peptides, proteins, but they attack microbes like bacteria. So we think that some of the people who have PG associated Alzheimer's, that the A beta may be partly part of the immune system fighting that infection. And there's some evidence that phosphorylated tau can do that too. So that's as much as we know about how those two mechanisms might relate.
For those that don't know, the amyloid and the tau that Dr. Detke is referring to are two proteins that are found in the brain that are associated with Alzheimer's disease. So I want to now go to the spring trial, which you're currently recruiting for. Before the spring trial, there was another trial, an earlier trial called the GAIN trial, gingipane inhibitor clinical trial. Can you first tell us a little bit about GAIN and what you learned from it and what its results were, and then we'll go right into spring trial.
Yeah, it's the perfect lead into the spring trial. So, as I said, there are these proteases, these little scissors that are going around destroying inside your nerve cells, and our drug targeted that. The little scissors are called proteases, and our drug is called a protease inhibitor. It inhibits them. And as I told you earlier, about 95% of patients with Alzheimer's had these in their brains after death. We knew that. So we decided to test a broad population of Alzheimer's patients. And the short story is that it didn't work in everybody. But we also knew that we had some biomarkers that could tell us that these patients had higher PG infection than others. We had actually 3 different biomarkers. One was the saliva test, but we also tested the blood and the cerebrospinal fluid. We did lumbar punctures in that study. And by all 3 of those measures, the patients who had higher levels of PG infection did better. It's a goodly amount of slowing. Of course, we'd like to see it stop or even reverse. We don't think it would reverse, but in theory, with this mechanism, you could slow it down more or stop it. Different analyses showed different amounts of slowing, up to 70%, but as low as more like 46%. But the primary analysis we did showed 57% slowing. So a really short version is we're doing the GAIN, that first trial over again, but we're only doing it in people that showed to have higher levels of PG infection as measured by the saliva test. And we think it will work in this population, but we have to prove that. There was one safety issue with the first generation drug in the first study, and we have a second generation drug that is better in a number of different ways. It doesn't look like it should cause any of those, the same safety issues. We have to prove that again. But for example, in the first trial, we did a drug that was a pill that you had to take twice a day. And in this trial, it's just a once a day pill. So we've improved it in several ways. And the key thing will be testing it in those patients that have positive P. gingivalis.
What types of side effects did you experience with GAIN that you're hoping that you rolled out for spring?
The main one was a liver side effect. You first can find liver problems early on by measuring certain blood tests, but then people can become sick if they get worse. We monitored the blood tests. A lot of people dropped out of the trial because these blood tests got up into a potentially dangerous range. But everybody recovered fully from it. But definitely something we don't want in the future going forward.
Obviously, you will monitor very closely for.
We'll monitor We'll monitor very closely. There are two goals in almost any trial like this: efficacy and safety. But patient safety is always not priority number one.
Moving to the spring trial, on the screen right now is a slide about the trial. It is called the Spring Clinical Trial, and the website to learn more about how to participate in this trial is www.springclinicaltrial.com. So you can go there, but this is a lot of information on the screen about it. One thing that I know is not on here that I'm going to just jump in and ask from Patricia, are ApoE4 carriers eligible for this trial?
Yes. And I think ApoE4 have a higher rate of ARIA, which is why that is I think a contraindication to the amyloid lowering drugs. As I said, we have no reason to think, and we actually have good data to think that we have no reason to think this will cause ARIA. We have good data from the prior study to show that this mechanism did not cause ARIA. So we will again monitor carefully, but that doesn't appear to be an issue at this point. The key eligibility criteria: PG positive saliva, biomarker confirmation, mild to moderate AD, age is there. If you're on a disease-modifying drug, you have to be off of that for 90 days, like Kisunla or Leqembi, before being in the trial. But if you're on symptomatic therapies, the acetylcholinesterase inhibitors and memantine at a stable dose, that's okay for you to be in the trial. And previous anti-amyloid theory is okay, but has to be washed out for 90 days.
And so you cannot participate if you are currently taking Leqembi or Kisunla. Okay.
Correct. But as you were pointing out, there are several contraindications. ApoE4, blood thinners. People can't qualify for the anti-amyloid drugs because of blood thinners. That's not a contraindication in the spring trial. The trial is up and running. The sites are starting to screen and enroll patients. In speaking to the site investigators, the doctors at the sites, they said, "Oh, this is, I have so many patients that I can't offer them anything because they're on blood thinners or ApoE4, or they'd already been through a treatment and they didn't qualify for another one." And so we're hopeful that this will be potentially helpful to a lot of patients.
I know the answer to this, but it is really, really difficult and something we see over and over and over again. So Payal wrote, are there any plans to expand participation to patients above the age of 80 if they are medically stable and qualify otherwise?
In a clinical trial, our primary goals are to understand if this drug is effective and safe. It is not to make every patient better. We'd love to see that happen, but if every patient got better, then there'd be no difference between placebo and drug, and we wouldn't have a drug that works too. So, and to that point, we want to test the population that we think are most likely to see efficacy, and you do tend to see different rates of decline in older populations. But then we also want to test it for safety. And as the age range goes up, on average, not everybody, but on average, more people have more comorbid medical problems, tend to be on more medications, and all of these additional variables make it harder and harder to come to the scientific conclusion. I really doubt that we'll be expanding the age range on this anytime soon. But if this trial is positive, and if the drug works the way we think it works, you step back and think about the fact that this might be very effective treating even earlier or even in prevention for patients with PG positive Alzheimer's. And it can be, I haven't seen things that have had a strict age label on them. And even so, they can be prescribed off label. I don't think it would necessarily hinder it much in clinical usage if it became approved. But again, hopefully we'd like to see this, if it works in Alzheimer's, to try it earlier, to try prevention trials. Those are bigger, longer, more expensive, harder to do trials, which is why you don't do them first typically, because it would take longer to get to patients that are waiting on the market. And finally, the last bullet point I'll add is I mentioned earlier that P. gingivalis has been involved in a bunch of other diseases like oral and esophageal cancers and so forth, that we would love to see it be helpful in too, if it could.
And I'm just going to go to a couple questions in the chat right now from Catherine. Did you see any differences in subgroup analyses, example, in ages or gender or race in the GAIN trial? And if so, how will those learnings be applied or evaluated in the spring trial?
That's a really interesting question. And for the most part, we looked at people who were ApoE4 carriers versus not, if they had at least one or two alleles. I think that group tends to decline a little faster. And therefore, if your placebo group is getting worse at a faster rate, you can sometimes see a better distinction between drug and placebo. And we did see a little bit of that and a little bit with the more severe patients, the moderate versus the mild. But we saw effects in both. Patients on symptomatic drugs versus not, we didn't see any real differences there. That first study looked at 6 countries. About 2/3 of the enrollees were from the US, but we had some countries in Europe, and we didn't see big differences there. We didn't see big differences in race or men and women. As you probably almost all know, that women are about twice as likely to have Alzheimer's as men, in part because women live longer on average than men. So we did see more women in the study, as you would expect, than men, but similar responses.
And how many participants are you looking to recruit for the trial?
We're looking to recruit 300. In that previous trial, in the group of 244 patients who had higher PG, we showed clear signs of efficacy in that group on a number of measures, the ADAS-Cog. One of the other things that was really compelling to us was that we saw positive correlations between the clinical outcomes on cognition and function and some other things. It was positively correlated with how much their PG went down. People whose PG levels went down more had greater slowing of clinical progression. So that correlation was really compelling to us. As was, we did see a small effect in the direction of supporting, as we age, our brains, we lose cells and our brains shrink a little bit. With Alzheimer's, as you all know, that atrophy or brain shrinkage tends to speed up in Alzheimer's. And we saw some slowing of that with our drug treatment. So there were several outcomes that led us to be very cautiously optimistic about the efficacy.
And Sarah asks, how often do you have to visit the site? I will travel as needed, but I'd like to know the frequency.
Generally, it's kind of a month or two apart, but for the first couple of months, out to first 2 or 3 months, the FDA wanted us to see people every 2 weeks to test for that liver safety. It's a little bit more frequent. It's every 2 weeks for the first few months, and then it stretches out to more like 4 or 6 or 8 weeks between visits. And that's typically how you treat patients and typically how clinical trials are designed.
How long does the trial go? How long will you
The short answer is a year. It's 48 weeks of treatment. The screening period at the beginning can take up to several more weeks, 10 or 12 weeks. We have to come to the site and get the test done and all that. But then the p-tau test has to be performed and the PG saliva test have to be performed and an MRI. We have an MRI at the beginning and the end because no risk of ARIA that we're aware of. We don't have to do them more often. But also the drug is a once-a-day pill, so that you don't have to do infusions or go to a different infusion center. There's no need for PET scans of any kind, no lumbar puncture or spinal tap in the study. Our first trial, we were doing a lot of stuff that was very experimental, and we learned a lot from that, and we've pared it down to make it more participant friendly.
In very non-technical terms, I would say for Alzheimer's, this is a very dreamy trial because you don't have invasive testing it ahead of time. It's a pill instead of an infusion. It doesn't seem to have, and you will be monitoring very carefully, serious side effects. You can participate if you're on blood thinners or ApoE4 positive. So this is one of the reasons why we really wanted to feature this trial on the program, because it is more inclusive and less invasive than a lot of the other types of trials. Mark and Kay want to know, if someone is on a course of antibiotics for some infection, is there a waiting period post the antibiotic use before becoming eligible for this trial?
Yes, we do, because there's a theoretical effect of antibiotics on P. gingivalis. We do want people to be off of them so we see which drug is doing what. I think you need to be off of them and stable for 30 days. And that's only systemic antibiotics. If you're using, eye drops or topical lotion or creams or something that for antibiotics, that doesn't significantly get into your bloodstream. It's not going to affect PG in your mouth or your brain or anything like that. And if you are on a course or something and you complete the course and then wait, you can come back and be rescreened. And of course, again, in the middle of the trial, someone has an infection and needs antibiotics. You have to take them. Patient safety is primary.
Again, great questions. From Peter, does the PG level bounce back once the drug is discontinued, or can it be considered a cure? I know we don't like to call things cures, or is it a cure for PG infection? Oh, good. That's a good qualifier.
That's a really great question. And one of the things I like to share with people is, typically we think of bacterial infections as being what us doctors call fulminant, but like really bad, really fast. You get pneumococcus in your lung, and pretty soon you are barely breathing, and you've got a fever of 104, and you need to go to the hospital for some IV antibiotics. But there are a couple examples of kind of slow moldering infections. One of them is tuberculosis, if you know that one. That one just is low grade and can last for years and takes like 6 months of taking antibiotics to eradicate it. Another one is HIV. Before we had treatments that really, for many, many years, we had treatments that could knock down the HIV load very, very low, but not really eradicate it, not really cure it. At present, our drug is a probably take for the rest of your life. And in fact, it's actually like the HIV drugs. The HIV drugs are protease inhibitors. They block those little scissors that cut up things. They just are different proteases in different parts of the body. But our drug's mechanism. So at present, we do not have a way to completely eradicate PG. The assumption is that it comes back if you stop it. But that's something we're working on. We've like when drug companies make a drug to target a specific target, they make zillions of them because most won't work for one reason or another. We have a couple of backup protease inhibitors, LHP 852 instead of LHP 588. And in theory, you might be able to layer on different protease inhibitors just like they do in HIV to get better effects. So all of that is probably down the road a few years, but those are some of the things that have potential for really improving therapies.
From Larry in the chat here, does the participant take a mini mental exam or an ADAS-Cog during the course of the trial? And these are cognitive tests.
Several of them. Our trial is designed like a lot of other ones are, that the MMSE is usually done to see if you're in the right range to get into the trial. And then the ADAS-Cog is the primary outcome. If it gets worse in the placebo patients and less worse in the treated patients, you'd expect that that ADAS-Cog, that's the sign of a positive trial that shows efficacy. And we monitor the MMSE over time too. It's a secondary cognitive scale. So yes.
This trial is about a year long. And so if all goes according to schedule, when will you be expecting to announce results?
Late 28 or early 29. We are projecting that it will take us about a year and a half to enroll all the patients. And then the last patient has to be treated for another year than that. So it's about 2.5 or so years. And there's a little bit of extra here and there.
And again, I know you're not a dentist, and we had so many questions about good oral care, which, as you emphasized, is so important. So I'm just going to ask one, and if you don't know, you don't know, but our friend Clifford from Baltimore, who clearly is a doctor and writes in for a brilliant question for every episode. What kind or combination of twice daily dental care in order of importance is good, better, and best? Manual rectangular brush, waxed dental floss, and or electric mechanical rotating circular brush? What time, before or after meals or at bedtime? Do you have anything to add on these?
I don't know the double-blind placebo-controlled trials or Oral-B versus manual brush trials, but I'll give you some clinical advice that a dermatologist has given me many times, which is use the sunscreen that you'll use. So if you won't use it because it feels slimy or it smells funny or whatever, so if you do a great job of brushing your teeth, with a standard old rectangular toothbrush. I use an Oral-B. It works well for me. Your dentist should be able to tell you if your at home dental hygiene is good, bad, or other. So yeah, I don't know the detailed data on that, but as a clinician, I would say if you find a toothpaste that you like and you use it twice a day, every day, and you find a floss that you like, I use the stringy floss. My wife likes the dental picks. If it works for you, it's better.
I think that's a great answer. And I'm going to close us with it's more of a statement than a question from Alan in Decatur, Georgia. But it says, thank you for your research. We, ALS folks, appreciate work like yours, which may shield other folks from being stricken with our disease. And so I just want to say you've had quite a career, Dr. Detke, and it's not nearly over yet. And so thank you for the work that you do.
Well, it's great to be doing this fun work. And like all of you, I mean, we know how common it is. Of the 3 living parents of my wife and mine, 2 have mild cognitive impairment, I think. And so we're all living with this. If you haven't been touched by this, it's just a question of time. So we're all rowing in the same direction on this one.
Thanks for listening to Let's Talk Alzheimer's. I hope that this episode conveys that researchers, biotech companies, and pharmaceutical companies are testing many interventions that target mechanisms and molecules other than amyloid protein plaques. This spring trial is actively enrolling now in mid-2026. So to learn more about it or to see if you or your loved one are eligible for this or other clinical trials, please visit Alzheimer's Disease Research Program at brightfocus.org. And there's a mechanism there where you can search for clinical trials that might be right for you. So I'll finish by saying, as I always do, life is so short. Tell everyone you love how much you love them. Give them a hug and hold them close. Have a great day and be well.
Thanks for listening to Let's Talk Alzheimer's. If this episode helped you better understand Alzheimer's disease, please hit like and subscribe to stay informed. And if this podcast would be helpful to people you know, please share it with them. For trusted information on Alzheimer's and the latest research towards a cure, visit brightfocus.org. Get the latest information on new medications, lifestyle changes, active clinical trials, and breakthrough technologies. Thank you to our sponsors, Lilly, Biogen, Eisai, and Genentech, for making this program possible. And thank you so much for spending this time with us.
Resonate.